Yeah.
Yeah. So good afternoon, everyone. So I'll be presenting on a homemade do-it-yourself aqueous sampling device for anterior chamber tap in endophthalmitis. So endophthalmitis can be post-operative, post-traumatic, endogenous.
Slides here, please. Slides, please. Can you put the slides on here, please?
So shall I start again? So good afternoon, everyone. I'll be presenting on a homemade do-it-yourself aqueous sampling device for anterior chamber tap in endophthalmitis. Endophthalmitis can be post-operative, post-traumatic, endogenous, or secondary to keratitis. Rapid diagnosis and appropriate treatment is required to save the eye from irreversible blindness. And accurate, appropriate, and adequate sampling is the key to precise microbiological diagnosis. So we can obtain various specimens which include vitreous taps, vitreous biopsy or vitrectomy fluid, which are more sensitive, but they have to be performed in the operation theater by a retina specialist, and a considerable time is lost before initiating the treatment, leading to further growth of organism inside the eye and cause worsening of the condition. Another specimen can be obtained is from the aqueous tap, which can be done by a comprehensive ophthalmologist and can be done before referring him to a retina surgeon. The purpose of the study was to compare aqueous tap performed by novel aqueous sampling device, which we call AST, with conventional sampling method using 26 gauge needle mounted on a tuberculin syringe, which is CST group, to compare the sensitivity results of AST with vitreous biopsy. And the design is a randomized controlled clinical trial. So this is how it is being done. This is a tuberculin syringe being used for withdrawal of the aqueous, and the basic difficulty is again you have to use both the hands to hold the syringe, and an assistant sometimes is required just to hold the eye before taking this sample. Whereas the aqueous sampling device is a 2 mm syringe is cut, the phalanges are cut, and a rubber dropper is mounted on the top of the syringe. This is then you just press the rubber dropper and you can get the, while you release the rubber dropper, you just collect the sample inside this syringe, which can be then sent for sampling. So doing it on the live on the patient, you see, just we have inserted the syringe, and you can hold the globe with the other hand. So needle is then withdrawn and fluid is then sent for microbiology, and you see the sample is collected into the syringe. So 40 clinically diagnosed cases of endophthalmitis were divided equally in 2 groups. The group A was the conventional technique with aqueous tap using tuberculin syringe mounted, 26 gauge needle mounted on a tuberculin syringe. Group B was 20 cases with aqueous tap using this novel device. All samples were collected by ophthalmologists in operation theater under peribulbar anesthesia. Aqueous tap was followed by vitreous biopsy and injection of intravitreal vancomycin and ceftazidime. After collection, samples were sent to laboratory for immediate inoculation and gram stain. So positive results means organism was detected on either gram stain or culture, and result was also compared with the vitreous biopsy to rule out any false positives. So coming to the results, both the groups were equally divided into the cause of or the etiology of the endophthalmitis into post-operative, post-traumatic, and endogenous, but they were equally divided. The aqueous samples were sent in 20, both 20 in the CST group as well as 20 in the AST group. But the lab returned samples as not sufficient in 9 cases out of 20 in the CST group, and in 5 cases in the AST group, that is the novel device group. So samples processed ultimately was 11 in the group A and 15 in the group B. Positive result came in 3 patients in the group A and in 9 patients in the group B. Vitreous biopsy was sent in 20 cases in all the patients, and they were almost same. 15 were positive in group A and 14 were positive in group B. So according to these results, the accuracy of the ASD was came out to be around 86.7% as compared to the conventional technique, that is 63.7%. The sensitivity again was very high, 81.8% as compared to CST, which is 42.9%, and specificity, because there were no false negatives and false positives, it was 100% specific. The results were 100% specific, and moreover, in more patients we were able to collect the adequate amount of sample for processing. So the advantages include adequate sample is obtained, no need of an assistant. Sample can be obtained by comprehensive ophthalmologist. Sample can be taken without delay at the primary center. Positivity comparable to vitreous biopsy, and it can be prepared immediately, or these instrument can be pre-prepared and sterilized for later use. The limitations of the study are that it's a very small sample size and it's not a blind study, though it was a controlled study, but it's not blind study because the lab technician was there to collect the sample inside the operation theater. So conclusion, though vitreous is the best source for obtaining a specimen for culture or smear examination, this novel device is easy to use and an aqueous sample is obtained using it before giving an intravitreal antibiotic by primary ophthalmologist, which gives adequate positive results. This gives adequate positive results, thus avoiding delay in treatment and worsening of the disease before referring the patient to the retina specialist. Thank you. Yeah. Yes. This is a safety valve which if you need to stop the sample collection or just a sudden spurt you throw. Yeah, you get them in the market. Yeah, yes, they are available. These can be ETO'd or this can be plasma also. Done plasma also. Yes. Yeah, you make the whole thing and then you can sterilize them. Yes.
Did you find it difficult when you have a thick fibrinous AC reaction? Because when you showed in the picture, one was fairly clear and the other was very...
Yeah, definitely you have to place in that area where the fibrin is less or the hypopyon is less dense so that you get an adequate sample. Otherwise, the fibrin is just going to clog into the needle. That will happen in both the cases.
That was a little disconcerting, because was there a bias because the examiner viewed those things?
I can't say, but we obtained the samples and he had collected those. They had been cultured and the positive results came from that only. Yeah, I said that it is not a completely blind study. There could be a bias in there, but most of the studies, only when the culture became positive or the gram stain showed something, then they were labeled as positive.
So both these techniques were done in a peribulbar anesthesia. So if you would have to do it one with your technique or innovation under topical, do you think it would be a useful?
It will be better because only then you can hold the eye and you can take the sample. Otherwise, if you are doing with a tuberculin syringe, you have to use both the hands to get the sample, and then assistant has to hold the eye.
Another thing is that this rubber stopper which you have, even if you remove the piston from the syringe and make it an open thing and just use your finger to open and close it, but I think that is a good enough tool. Means what additional advantage does it offer to a normal piston?
So when you are going to inoculate the sample again, you will need some pressure to pour that fluid into the sample. And secondly, again, you can definitely control, you can have more suction on this. With this, you can actually create a vacuum and suck easily. So you see, if you put it just inside the fluid, the needle, it won't suck, right?
So you want to do an active suction?
Active suction, yes.
Basically for anterior segment surgeons, like
basically for yes.
And it has similar sensitivity and specificity as to the vitreous sample.
Yeah, you can,
but not
you have
as good as vitreous.
Yes, it is not as good.
Aqueous sample itself is not considered to be
yes. It is not as sensitive as the vitreous.
As sensitive as.
Good morning all, and I'll be presenting uveitis and multiple sclerosis in Indian population. So these are series of representative 4 cases. The first case, it's 49-year-old female, and all the cases have presented with anterior uveitis symptoms like photophobia, redness, pain, and decreased vision. But priorly, she had left eye optic neuritis in this left eye optic neuritis and MRI brain and spine revealing demyelinating lesions, which are periventricular T2 hyperintense. And in all these cases, lab workup was negative for all infections like TB, sarcoid, and all autoimmune profile like SLE, Behçet's. And This is a presentation. It was bilateral granulomatous anterior uveitis, and with all granulomatous KPs here, granulomatous KPs with some corneal haze, broad posterior synechiae with complicated cataract. This is fundus picture with mild vitritis, more in the right eye and in the left eye. So this picture onto the left is granulomatous KPs in one of those recurrences post cataract surgery. We treated with oral steroids, but she developed avascular necrosis of hip, and so she has to be switched to mycophenolate mofetil 1 gram BD as steroid sparing agent, and in 2 months she shows good response. This is another case, 18-year-old female presented with granulomatous anterior uveitis and pars planitis with peripheral vascular sheathing. In this particular case, had neurological symptoms like numbness in right big toe and muscle fatigability after aerobic exercise, which is Uthoff's phenomenon. And the neurologist has treated this particular case with subcutaneous beta-ferron injections for 1 year. And also we did mycophenolate in this case. But 4 years later, she develops ICE kind of syndrome with iris atrophy and choroctopia. And she, with uncontrolled IOP, she undergoes TRAB, which fails, and then AGV with PKP. This has been treated with MMF and showed good tolerability and response. Again, the follow-up MRIs revealed decreased enhancement and also decreased in the number of lesions. This is another case, 38 female, again left eye optic neuritis, but in this particular case, MRI brain was normal except for the thickening of optic nerve. And interestingly, CSF revealed oligoconal glands, which were included in the recent criteria for diagnosis of MS. And 10 months later, she developed acute granulomatous anterior uveitis with again pars planitis and all of that. She tolerated MMF well. This is the most challenging case with the longest follow-up of 20 years. She's 41-year-old female, and she was known MS and major depressive disorder for 12 years before. 12 years later, she develops this uveitis, which was recalcitrant to mycophenolate, which was otherwise tolerated well in other cases. So we did intravitreal methotrexate once a week for 1 month in both the eyes. And since she responded well to methotrexate, we switched from MMF to 20 milligram methotrexate. This was a peripheral picture with snowballs and these stars showing pars periphlebitis, and this periphlebitis is known to be a marker for aggressive disease and protracted illness. Post-treatment, all this periphlebitis disappears and the snowballs also decrease in number, and these are representative MRI brain images with T2 hyperintense characteristic lesions perpendicular to the body of lateral ventricle. And this yellow arrow points towards a rim of hyperdense lesion with central hypo, indicating the chronicity of MS. This is again T2 sagittal showing central hypodense with rim of hyperdense, indicating chronicity. All these black holes which point towards again indicate chronicity. And this is atrophy of corpus callosum. This is a summary of all cases. So all females and both eyes were affected in mostly all. In spite of all the protracted illness, they maintained good vision. And anterior uveitis was in the form of granulomatous with mutton fat KPs, and it was intermediate uveitis with snowballs and peripheral phlebitis. The longest follow-up we had was for 20 years. And the uveitis developed either before or after MS in almost all the cases. This is to summarize all the findings. These were the neurological symptoms that we found: numbness in the toe, muscle weakness, fatigability, peripheral limb weakness, etc. And the systemic history and HRCT lab workup was all non-contributory of any other uveitic etiology. All the characteristic MRI lesions. But interestingly, one didn't show any MRI features, but that had CSF oligoconal glands. And all developed secondary steroid-induced or secondary angle closure glaucoma, and all of them tolerated MMF very well for many years. One recalcitrant, we tried methotrexate, responded well. Despite all this, all maintained good visual acuity. I thank Biswas sir and AIOC for the opportunity. Thank you.
Systemic test that you carried out. So did you do a CRP and ESR and differential? Of course, you could have done.
Yeah, if all the workup, yes, sir. ESR, CRP, RA, ANA, ANCAs, all was done for the autoimmune part of it.
Yeah, but basically
Yes. Like TB workup was done, MAN2, QTB and HRCT chest. All. No, not really, because all the patients had MRI characteristic lesions, right? And the skin test and all of them was negative, so PCR was not mandated.
So if you look at your case number 3, that was the case where the MRI was normal to start with.
Yeah.
What in the granulomatous KPs did you find which made you think to do a CSF tab for that patient?
That was a previously tabbed patient which had come after, sir.
Means if
She
I
had
have to ask
left
you a
eye
question
optic-
that what are the findings on the anterior uveitis which will make you suspect that it is a case of a multiple sclerosis? Can you just tell me, enumerate some features which will help us?
Got it, sir. I think there are no pathognomic clinching anterior uveitis or in specific uveitis features that are marker for systemic conditions. It's only when others are negative and you have some neurological findings or something like that, that's when you do an MRI. It's not like you have any clinching pointers ophthalmologically, clinically.
In intermediate uveitis, anything that will make you suspect that there is
Retinal periphlebitis is one marker, ma'am.
where?
Other than
Where in the retina?
where, in any quadrant you mean? Quadrant.
Not quadrant.
I think peripheral retinal. Yeah.
And you don't get any other cause, then you can think. What is the other condition which will produce the same picture? Intermediate uveitis, peripheral retinal vasculitis. You have ruled it out, but more common.
All other infections, it's tuberculosis, ma'am.
Non-infectious.
Non-infectious, sarcoidosis, SLE.
Sarcoidosis.
Okay, thank you.
This is my conflict now. Next.
About the use of enhanced depth imaging OCT in management of cases of chronic VKH and its comparison with what we see on ICGA. So there are no financial interests or disclosures to be made. So VKH, it's a primary autoimmune stromal choroiditis in which uveitis and exudative RD can be seen. Along with that, other manifestations are there, neurological manifestations, auditory or dermatological manifestations. Now, chronic VKH, it's a subclinical evolution. There will be recurrent bouts of inflammation. ICGA has been thought to be a standard tool so as to evaluate such patients. So, on which we will be seeing hypofluorescent dark dots, which are basically immune cell infiltration around the remaining choroidal melanocytes, which represents the areas of impaired diffusion. Now, EDI OCT has come up as a valuable tool so as to evaluate these lesions in such conditions. Our objective was so as to highlight the use of EDI OCT to evaluate the activity in chronic VKH cases. Now, the materials and methods was a retrospective study which was done at a tertiary eye care center in southern India. The patients who were diagnosed with VKH from the period of about 2010 to 2022 were included in this study. So, we had a pool of 48 patients, 96 eyes. And the mean follow-up duration of these patients was 1 year. Now, the patients included in the study underwent all the routine examination like BCVA, IOP was examined on Goldman's applanation tonometry, slit lamp examination, and fundus examination. And the grading of the uveitis was done on standardization of uveitis nomenclature. Imaging modalities that we used were for fundus photo, Topcon fundus cameras, or Optos wide field imaging systems. And then FFA was done, ICGA was done. For EDI OCT, it was Spectralis Heidelberg which was used. Now, EDI OCT was repeated at all subsequent visits of the patients after the diagnosis, and ICGA was done whenever we wanted to monitor some activity, there was some suspicion which was there. Now, the results showed age ranging from 9 to 65, so the median age was 42. Female to male preponderance was 3:1. Now, the way we evaluated the lesions on ICGA and EDI OCT is that the features of the margins were seen on ICGA, that how well defined or poorly defined or irregular margins of the hypofluorescent dark dots was there. And on EDI OCT, we looked at the reflectivity of those particular corresponding lesions, whether they are hyporeflective or there are showing features of both hyper or hypo or only hyperreflective. Now, if we see this one case example where we look at the fundus like a sunset glow fundus, where we are not able to make out clinically whether there are any lesions or not. So we did the FFA and ICGA. On FFA also there are absolutely no lesions to be seen, but if we look at the ICGA, there are multiple HDDs or hypofluorescent dark dots which are there. Now from one of those areas, if we pass from this particular area, if I pass and do the OCT of this particular image or this particular lesion, then what we see over there correspondingly is a lesion which is showing some amount of hyperreflectivity, but not exactly compared to this particular image where we are looking at a completely healed choroidal lesion, which on OCT is going to be showing severe hyperreflectivity. So comparatively, we could make out that there was some amount of activity in the previous lesion in the patient in which we did the scans. So when we analyze the data of these particular patients clinically on ICGA and EDI OCT, so what we looked at was that on the healed number of lesions which were being seen clinically, ICGA and EDI OCT. So EDI OCT shows a significant number of more eyes having healed lesions compared to the other two modalities that we used. Active lesions again slightly on the lower side when it comes to EDI OCT, and both active and healing. Now both active and healing on the basis of clinical, it was difficult for us to pick up because what we based clinically, it was on the vitreous haze or the vitritis that we saw. But on EDI OCT, it was very clear for us to make out whether a lesion was showing both the features of healing as well as some amount of activity based on the reflectivity that we saw. And active to healed, again, healed lesions were more when it came to the OCT. Now the same thing on the bar graph. So discussion in this particular case that has emerged as a valuable tool for monitoring the activity in VKH cases, chronic VKH cases. The same thing like the active lesions clinically and ICGA, which were seen to be more, were showed to have healed lesions when it came to the OCT. Now there are some comparative studies which have been done. Now this one particular study, but they looked only at the active lesions in the cases of VKH, where they evaluated the thickness, the shape, irregular margins, then hyporeflectivity, anterior, posterior, and lateral extent. Their argument was that when it came to the treatment of the active lesions in VKH, especially the initial phases, the anterior posterior dimensions of the lesion will be reducing much faster compared to the lateral extent of the lesion, which will be better picked up on OCT. So they also supported the argument that OCT is a better tool once the lesions are picked up, and so as to monitor those lesions, how our treatment is actually working. So our study, we looked at the chronic cases. There was presence of, so we looked at clinical appearance, vitritis. When it came to the ICGA, we looked at the margins, regular or irregular. And when it comes to the OCT, we looked at the reflectivity, how homogeneous the reflectivity was. Then, and also corresponding means comparing it with what we saw on the ICGA. So conclusion is that EDI OCT images will provide a better understanding of the disease activity in the lesions in VKH disease and helps with the optimization of the titration of the treatment. The challenge that we will be facing when it comes to the OCT is that beyond the posterior pole, it is difficult so as to analyze the lesions once it comes to the OCT, so as to capture those images. So that's my talk. Thank you.
It was simultaneous ICG and EDI OCT?
Simultaneous, yes sir, means not at all visits, but then definitely in the initial visits there was ICGA which was done and the OCT was also done, but then a few lesions had to be picked up because analyzing every lesion, passing the scans through that lesion becomes technically difficult so as to manage in the OPD. And also some of the lesions that we saw, like the one which I showed at the posterior pole, which was there, some of the peripheral lesions, so those lesions were monitored in certain, means in particular eyes on subsequent follow-ups, that how these lesions are behaving when it comes to the follow-ups.
So, so on this basis, you decide the treatment like tapering of drugs, tapering of steroids, or tapering of immunosuppressants. So what is the practical role of this study?
Sir, because now if we look at the follow-up of our patients also of this particular pool, there are patients who have come for follow-ups over the period of 9 years. Some have come only, so the mean duration is 1 year. So when they come over a period of such 4 years or 6 years only for 2 or 3 visits, when they come for the second time or the third time, looking at those patients and just seeing that, okay, on the ICJ there are some lesions and whether to start the treatment or not, not, it becomes difficult. If we do the OCT in through those particular images, then definitely we are able to pick up that, okay, if there is some activity, we can subject those patients to the treatment, or we might as well just observe the patients on a closer follow-up if they are ready to do that.
What statistical test did you do in these patients to see what was the sensitivity and the specificity of your test, and say that which imaging is better than the clinical examination? So what was your sensitivity and specificity of these?
Sir, we actually went with the numbers that I have displayed as such. So statistically, like going and looking at the p-values of it, the significance of it, we have not yet done.
Yeah, I also feel that the size of the granulomas is not really what we base our treatment and treatment tapering on.
Right.
So, to give you a clinical, like the role of this in clinical practice is not going to be. As an imaging tool, agreed.
Yes, ma'am.
Especially, like you said, to go through each of those lesions and look for the size of it. One, not practical. Two, we don't look at the activity of the granulomas anyway.
Right. But going ahead, conducting a larger study with a bigger sample size may help us to find out something new in this. Right.
Okay.
Thank you, sir. Thank you.
So now we move on.
I'm Dr. Atul, and I'm going to present my topic on measurement of inflammatory cytokines, biomarkers from tear samples from the patients of uveitis. There's no financial disclosure. So normally cytokines are present in which are responsible for all the uveitic problems which are seen in these diseases. So any abnormality or atypical cell population, cytokine expression, and cell-to-cell interaction, these can be seen in this cytokine uveitic entities. So different pattern of cytokine expressions are seen, which can be TNF alpha, and IL-1, IL-2, IL-6, and 17. So the cytokine, there is already cytokine-based disease taxonomy which is present for personalized treatment strategies towards most of the systemic diseases like rheumatoid arthritis, giant cell, psoriatic arthritis, and ankylosing spondylitis. So our aim of the study was to determine the cytokine expression profile in the tears of patients with uveitis. It was a cross-section study for the tear analysis in these patients in a tertiary eye care center from South India using a biomarker kit which was used in aged MASH controls. Ethical committee approval was taken. Schirmer strips were used to collect the tear samples, and these were stored in 1.5 ml of microcentrifuge tubes. Extraction buffers were added, and after mixing for 5 minutes, 50 microliters of tears were added to the circular, specifically designed circular wells in the cartridge, and wash buffers were added in the triangular wells as well. So these were measured using a fluorescent reader with BioM Pathfinder, which is specially designed in our hospital. And these were used to analyze IL-1 beta, IL-6, IL-10, IL-17A, TNF alpha, MMP9, VEGF, SICAM1 in these tear samples. Statistical analysis was done using Kruskal-Wallis test and with Dunn's multiplication comparison test. So inflammatory factors measurements were used for this personalized treatment strategies were the values of these specific cytokine values, and this is the tubes which you can see here. So on results, there are total number of 486 eyes which were evaluated, out of which 272 were uveitic and 214 were healthy eyes. The age group was 6 to 90 years with median age of 44.5. Mainly the females were around 74. On anatomical classification, there were maximum patients were of posterior uveitis followed by anterior and pan. The total number of patients were around 156 patients were of autoimmune diseases, followed by idiopathic and infectious diseases, and around 214 were controlled patients. So this is a scattered dot bar graph which you can see, which shows that around IL-1 beta, IL-6, IL-17A, TNF alpha, MMP9 and S-ICAM levels were significantly elevated in uveitic patients, and major etiology which was involved was autoimmune, followed by idiopathic and infectious. So in anterior and posterior pan-uveitis, around this IL-1 beta, IL-17A and TNF alpha and MMP9 were elevated, while IL-6 and S-ICAM were mainly elevated in anterior and posterior only. Episclerotic patients had IL-10 levels which were high. Post-fever retinitis had high levels of IL-1 beta, IL-6 and MMP9, and viral had mostly MMP9 levels which were significantly high. So in comparison with tubercular entities, post-retinal fever had a higher level of VEGF levels. This is a case example where a bilateral retinal vasculitis with retinitis was there. The patient had high levels of MMP9 S-ICAM levels along with VEGF in both the eyes, which you can see here. So after treatment, these levels were significantly reduced. On discussion, MPO ANCA positive patients had higher serum levels of soluble ICAM and soluble ELAM, which were present high during active phase and were slowly declined during the treatment phase. As ICAM levels may reflect the extent of microvascular involvement in RA patients. One study noticed that the concentration of IL-6 and IL-10 were significantly high in non-infectious uveitic patients in comparison to normal healthy patients. And IL-23, IL-1 beta, IL-15 and EGF and fractile ratios and MCP and CCL2 were elevated in patients with uveitis, and VEGF levels and TGF beta 2 were high in these patients compared to the normal controls. So based on our current knowledge and analysis and quantification of these cytokines and specific tier biomarkers can help in better understanding of the pathogenesis of these uveitic entities to plan the future targeted therapy in uveitic also. Thank you.
Are you aware of any other method of collection of tears?
Usually in previous studies, some studies have been done where they had used capillary tubes. So right now we are the main purpose of this is to provide this facility. We have a biomarker BioM Pathfinder which is there. You can see in that picture, which is not commercially available right now, but we are planning to go for commercial availability. But right now we are just finding out its horizon basically, just to know whether how much.
That will give you better collection
so
of the
it's
sample.
basically a OPT based procedure. We collect the samples there. It takes around hardly 15 minutes to do the whole procedure. So we can test it at every follow-ups, so to see whether the levels are increased or what's the cause. In other patient we had done, one patient was there, Medum, which we had done and followed it for around 3-4 follow-ups. It is a different study which we had done. So in that also we have found that the CME was resistant in the patient, and the cause was not the VEGF itself. So we did use another drug which was there, which helped in reducing the CME and other.
Did you find any difference in the pediatric and the adult? You had some JI.
Actually, there is also another study which is going on, which my colleague will also present. So there's a presentation in next few days. So he will definitely.
Difference between eyes where you had idiopathic uveitis versus secondary uveitis. So if you look at your control group, I think they are age-matched patients who were not having any disease or not having any uveitis. They were normal patients. So if I have to ask you, there should have been a third control group where probably you should have taken an eye where there was no idiopathic uveitis or a uveitis, suppose a rhegmatogenous detachment causing uveitis?
That's actually, there are two ways this cytokine can be used, which we can see here. Mostly in the non-infectious uveitic patients. Other is in these, some studies have been done where rhegmatogenous and some retinal diseases which has been there, has different levels of cytokines. So we haven't done that part of study, but because it was done properly only in uveitic specifically, so that study we have, but we are looking for that also.
Thank you.
Thanks. Thank you.
So now we move on to the next presentation. Dr. Ninian Jacob, our retinal pigment epithelial analysis in acute VKH.
Good afternoon, everyone. My name is Nainan Jacob. I am a veterinary retinal fellow from L. Prasad Institute, Vijayawada, and I will be presenting our paper on retinal pigment epithelial analysis in acute VKH disease. So, as we all know, VKH disease is an autoimmune multi-system inflammatory disorder directed against melanocytes with ophthalmic, neurologic, otologic, and dermatological manifestations. In the eye, it presents as granulomatous posterior and panuveitis with diffuse choroiditis, vitritis, serous retinal detachment, and cystoid macular edema. Though the diagnosis is practically clinical, we can use FFA, ICJ, and OCT for confirming our diagnosis. So, objective of our paper was to assess the morphological features of the retinal pigment epithelium during the acute phase of disease and following its resolution, and its probable role as an OCT biomarker during the acute stage of VKH disease. This was a retrospective observational single-center study conducted between 2016 to 2021, which included consecutive cases of acute VKH disease, and we excluded other cases of coexisting retinopathy and other causes of diminution of vision. The data collected include the demographic data, the best-corrected visual acuity, duration of symptoms, and the duration of disease. The retinal pigment epithelial characteristics which we analyzed included the RPE reflectivity and the RPE thickness, both during the acute phase and following resolution. We also collected the total choroidal thickness, the central macular thickness, and analyzed certain morphological features of the RPE and the choroid during the acute phase and following resolution. We use the Topcon Triton Swept Source OCT for image acquisition, and for image analysis, we use ImageNet software for measuring the central macular thickness and the choroidal thickness, and the open access software ImageJ for measuring the RPE reflectivity and RPE thickness. So this is a representative image of how we measured the RPE reflectivity. Using the oval selection tool in ImageJ, we selected our area of interest on the RPE to measure the overall RPE reflectivity or the mean gray value. We measured RPE reflectivity from 3 locations and then averaged it. And we measured the reflectivity under the fovea, under areas of attached retina, and under areas of detached retina during the acute stage and following resolution. And this was how we measured the RPE thickness using the inbuilt caliper of ImageJ. For data analysis, we converted the Snellen visual acuity into the logMAR, and a two-tailed paired t-test was used to analyze the variables pre and post treatment. And the Pearson correlation and linear regression analysis was used to assess the relation between the various different continuous variables, and a p-value of less than 0.05 is considered significant. Our cohort included 29 eyes and 29 patients and 55 eyes, and we excluded 3 eyes because of poor image quality. We had 9 males and 20 females, with the average age being 33 years, with the range ranging from 9 to 57 years. And the mean duration of symptoms prior to presentation was around 15 days, and the mean duration of disease was around 90 days. In our results, we noticed that there was a significant improvement in the best-corrected visual acuity following resolution, and as seen in other studies, there was a significant decrease in the central macular thickness as well as the subfoveal choroidal thickness. What was new in our study was that there was an overall increase in the RPE reflectivity following resolution, more clearly seen in the area under the fovea as well as area under the detached retina. Also, we noticed that the RPE thickness decreased following resolution in all areas, that is under the fovea, under attached as well as detached retina. On correlation analysis, we noted that during the acute stage of the disease, the RPE thickness under the fovea correlated with the subfoveal total choroidal thickness. Also, there was a correlation between the baseline BCVA and the duration of symptoms, as well as the final BCVA and the duration of the disease. However, we could not find any correlation between the RPE reflectivity and thickness during the acute phase of the disease and following resolution, nor could we find any correlation between the change in RP thickness or a change in the RP reflectivity with the change in BCVA following resolution of the disease. So these are some of the morphological features we noticed. So in this image, we can see in the inset what is marked with the red asterisk as tiny hyporeflective lesion within the RP, which are these RP evacuations. We presume that these RP evacuations occur due to increased inflammation and edema of the RP. This was seen in around 15 eyes of our study cohort, and all of these resolved after treatment. Another interesting feature which we noticed in our study cohort was these well-localized hyperreflective lesions on the RP seen in eyes following resolution of the disease, seen but only in 3 eyes. The choroidal hyperreflective dots are these well-circumscribed lesions within the choroid, seen in around 85% of the eyes during the acute stage, and all these resolved following resolution of the disease. And in our patient cohort, almost since even though the vision improved in all our patients, a lower baseline best corrected visual acuity, higher baseline total choroidal thickness, shorter duration of symptoms, the increased thickness of the RP under the detached retina, the presence of bacillary layer detachment, and the presence of hyperreflective choroidal dots showed a greater improvement in visual acuity. But on multivariate analysis, only a lower baseline BCVA and the presence of bacillary layer detachment at baseline showed a significant effect on the final improvement of BCVA. So to conclude, we propose that the RP thickness and reflectivity can act as surrogate biomarkers of choroidal activity and inflammation in acute stage of disease, especially in conditions where due to the intense inflammation, we may not be able to assess the choroid due to poor image quality. And then we noticed that RP evacuations and choroidal hyperreflective dots are novel OCT features seen in our cohort of PKH patients. Thank you.
In one of the photographs, you showed that RP thickness was increased because of some depositions. So it could lead to false measurement like this. So
we excluded this area, sir. This was just an image finding we noticed, but and this is seen only in 3 eyes. So we excluded this to prevent any outlier value.
So what I wanted to know is that if you look at the mean duration of your symptoms in your patients, it's almost 15 days. That's too high for a patient to be having with acute VKH. Now, did you look into different categories of patients who are presenting to you within 3 days, 3 to 7 days, 7 to 14 days, 14 days and beyond, and then look at the RP reflectivity and the thickness in those patients, because that will actually give us a true picture?
That analysis we actually didn't do, sir. Like based on the duration of symptoms, we didn't categorize the patients.
Also, you said that there is no change in the reflectivity from acute stage and when you followed up the patient up when the disease became quiescent, isn't it?
No, ma'am. I told that the reflectivity of the RP decreased significantly, decreased following a resolution.
Okay. Well, just go to your next slide. Next one.
What I mentioned here was that
resolution.
There is no correlation between the reflectivity and
correlation.
thickness.
Yeah. So then your result means your conclusion doesn't.
No, ma'am. There is no correlation between the reflectivity and thickness. But what we are proposing is that the thickness of the RP increases during the acute stage, and because thickness is increasing, we assume that it is due to the edema of the retinal pigment epithelial cells, and because of that edema, the reflectivity decreased. And following resolution, when the thickness decreased, the reflectivity is again better following resolution. And there was no discrepancy in the image quality, because during the acute stage and following resolution, what the image quality which we obtained from the OCT machine, there was no significant difference in that also.
good. Got something new to learn. RP evacuations and thickness. So now we move on to the next.
Thank you.
Thank you.
Dr. Rashri, ocular granulomatosis, polyangiitis, a case series.
Now, did you look into different categories of patients who are presenting to you within 3 days, 3 to 7 days, 7 to 14 days, 14 days and beyond, and then look at the RP reflectivity and the thickness in those patients, because that will actually give us a true picture?
That analysis we actually didn't do, sir. Like based on the duration of symptoms, we didn't categorize the patients.
Also, you said that there is no change in the reflectivity from acute stage and when you followed up the patient up when the disease became quiescent, isn't it?
No, ma'am. I told that the reflectivity of the RP decreased significantly, decreased following a resolution.
Okay. Well, just go to your next slide. Next one.
What I mentioned here was that
resolution.
there is no correlation between the reflectivity and
correlation.
thickness.
Yeah. So then your result means your conclusion doesn't.
No, ma'am. There is no correlation between the reflectivity and thickness. But what we are proposing is that the thickness of the RPE increases during the acute stage, and because thickness is increasing, we assume that it is due to the edema of the retinal pigment epithelial cells, and because of that edema, the reflectivity decreases. And following resolution, when the thickness decreases, the reflectivity is again better following resolution. And there was no discrepancy in the image quality, because during the acute stage and following resolution, what the image quality which we obtained from the OCT machine, there was no significant difference in that also.
Good. Got something new to learn. RP vacuolations and thickness. So now we move on to the next.
Thank you.
Thank you.
Dr. Rashri, ocular granulomatosis, polyangiitis, a case series.
Very good afternoon to one and all. Our study was on the condition ocular granulomatosis with polyangiitis. So granulomatosis with polyangiitis is a life-threatening disease previously called as the vaginous granulomatosis. It belongs to autoimmune multisystem vasculitis affecting the medium and small size vessels. And it belongs to a group of diseases called ANCA-associated vasculitis. The ocular involvement is seen in about 1/3 of the patients, which is approximately 30 to 40%. So this condition has a triad of vasculitis, tissue necrosis, and granulomatous inflammation. So there are a lot of triggering factors like Staph aureus infection, pro-inflammatory cytokines, genetic factors have been studied, which triggers a neutrophil and makes it primed. And in turn, it releases antigens called myeloperoxidase, MPO, and the proteinase 3 antigen. These antigens in turn are recognized by the B cells, and in turn they produce antibodies, which are the ANCA antibodies against these antigens, which in turn gives out a major inflammatory cascade and causes damage to the endothelium, thus causing vasculitis and granuloma formation. So this picture depicts all the systemic features of granulomatosis polyangiitis from top to toe. So our study was to analyze and describe the various ocular manifestations, diagnostic methods, and treatment regimen of GPA. It was a retrospective study done at our center with 14 patients over a period of 14 years. So all patients would undergo a regular ocular examination, routine blood investigations, and ANA and ANCA profile. Wherever needed, if MANTO was positive, we would do a CT chest and ultrasound abdomen to rule out tuberculosis. And if in case of an intracorneal mass, we would do a CT orbit. So out of 14 patients, there was a male preponderance, and the median age of presentation was 46 years. So the most common ocular complaint with which the patient presented to us was redness and eye pain, and the systemic complaint with which they presented was joint pain, hearing loss. And scleritis was the most common presentation which was seen, and next comes peripheral ulcerative keratitis. And in scleritis, necrotizing scleritis was a prominent feature of GPA, and we also had cases of simple episcleritis, which was diagnosed to be a GPA, followed by posterior scleritis, granulomatous panuveitis, optic atrophy, and intracorneal mass. So this is a picture showing necrotizing scleritis on the left, and scleritis with peripheral corneal infiltrates, which will develop into peripheral ulcerative keratitis. So out of 14 patients, 8 patients exclusively presented to us with ocular feature being the primary presenting symptoms. And out of those 8 patients, 6 of them had simultaneous systemic involvement. The lab diagnosis, ESR was found to be really high in these patients, ranging from 50 to 150 millimeter per hour, thus depicting the acute phase reactants like immunoglobulins. And the hallmark presentation of these patients with ANCA antibodies was seen. And there are 2 types of antibodies. It is P-ANCA and C-ANCA, depending upon the immunofluorescent staining. It was called the perinuclear staining or the cytoplasmic staining. So 10 of our patients were positive for C-ANCA, 1 for P-ANCA, and 3 did not have any ANCA positivity, yet we should not rule out vaginous even if ANCA is negative, and it has to be confirmed through biopsy. Biopsy still remains as the gold standard method for
diagnosis. Though lung, renal, and orbital biopsy have higher sensitivity, upper airway remains the easiest site for biopsy specimen retrieval. And a study by Maziak et al. Showed that in non-renal biopsies, features of necrosis, vasculitis, and granulomas were most commonly seen. In our patients, we retrieved specimens from lacrimal gland, nasal septum, limbal nodule, intracornal lesion through orbitotomy, ethmoid sinus, and vitreous. So 5 of our patients had features of granulomatous inflammation, 4 had necrosis, 1 had vasculitis and granulomas, and in 1 patient we also saw positivity of CD20 and CD3, which shows that it has a B cell lineage. So these are slides from our patients. On the left-hand side, we see a giant cell, and on the right-hand side, this is a vessel with the central leukocytoclastic vasculitis. Imaging, we do CT chest for pulmonary involvement, MRI for vasculitis, cerebral vasculitis, and CT orbit for orbital mass. And we'll have to look out for features like nodules, cavitations, and alveolar hemorrhage. And we should be very careful in ruling out tuberculosis because these findings also come in tuberculosis. So the American College of Rheumatology criteria 2017 had given importance for ocular features, but sadly in 2022 when the criteria was updated, the ocular involvement was completely removed. So we followed the 2017 criteria and we found that 9 out of 14 patients fulfilled the criteria. Treatment, glucocorticoids play the primary role. Along with it, 3 patients were treated with methotrexate, 10 with cyclophosphamide, and 1 with MMF. Though 1 patient who was treated with MMF was ultimately shifted to rituximab, and 1 patient with cyclophosphamide also needed rituximab infusion. So this was post-remission. So outcome, 7 patients still continue to be on immunosuppressants, 2 patients attained ocular and systemic remissions, and 5 patients have lost follow-up. So take-home points would be GPA is a life-threatening disease with high mortality rate without immunosuppression. A very high ESR value in any type of uveitis should be evaluated in detail, and it is extremely important to rule out infectious disease like tuberculosis. And immunosuppressants and newer biological agents are a game changer. And every ophthalmologist must know the ocular and systemic features of GPA, as early and prompt diagnosis can be life-saving. Thank you.
Do you know why the name was changed?
Yes, ma'am. Actually, Dr. Vagino, he had an involvement. He helped the Nazis in the Second World War. So ultimately, the name was changed to granulomatosis with polyangiitis.
Okay, no other questions.
Thank you.
Kindly don't evaluate me, please, because I'm doing it for presentation's sake, because this is a little very specific and specialized paper. That's what I'm presenting. Kindly, don't evaluate me. Is the histopathology, immunohistochemistry, and molecular biology in eviscerated and enucleated specimen of end-stage ocular inflammatory disease. I'm a pathologist. To describe the histopathology, immunohistochemistry, and molecular biology in various end-stage ocular inflammatory pathology. We had in 10-year period 18 such rare cases where we need to have unfortunately eviscerate or enucleate the globes secondary to the intraocular inflammation. Can this specimen be used? That was the question we tried to answer. And we did the histopathology, immunohistochemistry, and PCR study of the paraffin section of such cases. I'll discuss this scenario. We got the fortunately to have a case of VKH and 9 cases of sympathetic ophthalmia. VKH, interestingly, we found CD20, that is a B cell positivity, in addition to the CD3 T cell positivity, which is rare. Sympathetic ophthalmia, as usual, we showed granulomatous inflammation with predominant CD3 positivity. And this is a B cell positivity in a case of sympathetic of VKH, and you can see that the B cell positivity, and this is the lymphocytic infiltration. And this is a case of inflammation in the ciliary body, as well as the choroid is the granuloma formation, and this brown color is the CD3 positivity, T cell positivity was seen. In tubercular panuveitis, we have got 3 cases where Mycobacterium tuberculosis DNA was found to the positive station, but you can see that caseation necrosis over here, which is very characteristic, and the PCR was positive for MPV64 and IS6110 region. In case of Eales disease, we fortunately have 2 eyes of Eales disease. It's not usually enucleated, become the chronic non-granulomatous inflammation and blood vessels of the retina. One of the patients who was blind, I almost begged the patient to unravel the mystery of Eales disease. And really, it was fascinating to find out the PCR Mycobacterium tuberculosis DNA in the enucleated tissue specimen and show the inflammatory cellular infiltrate. And this is a case which has got other eye features suggestive of Eales disease, but histopathology showed vascular channels surrounded by lymphocytic infiltration. And this lymphocyte is interestingly was CD8 T suppressor cells positive and CD3 positivity. And in a case of pars planitis, which you don't remove the eye, you could see the acellular tissue corresponding to the pars plana snow banking areas with chronic granulomatous inflammation. And we could find out the glial fibrillary acidic protein seen that this is a glial tissue. And it was positive for CD68, that is a macrophage marker, CD3 T cell marker, and CD8 T suppressor cell marker. In acute retinal necrosis, very interesting is case, and where you could see the peripheral retinal necrosis and inflammation, and there is an occlusion of the blood vessels were seen, and there is a T cell infiltration, and we could find out the inclusion bodies also, and PCR was positive for paraffin section, HZV DNA was nested and real-time PCR. And this is a case of a unfortunate case of a scleritis, which was treated with the wrongly by me with the steroid and immunosuppressive agents. We didn't know that this is a TB. It masqueraded as a like of non-infectious uveitis. IVMP was given. Patient lost follow-up. When he came, there was a perforation and the painful blind eye was removed. And this showed granulomatous inflammation. I was surprised with the giant cell formation, and PCR showed Mycobacterium tuberculosis DNA. And this is a case of tubercular sclerouveitis, which is reported as a kind of a thought to be a tumor, but there is no tumor. There is a granulomatous inflammation, RP cells, IAB bacilli are seen, PCR is positive for Mycobacterium tuberculosis DNA. In conclusion, we are still lacking the knowledge regarding various ocular inflammatory disease is still evolving, and histopathology, immunohistochemistry, and molecular biologic study of this end-stage disease can throw light into the pathogenesis and maybe, who knows, help in the treatment of the future. Thank you very much. Please don't mark.
JB sir, hats off. Just for that fabulous presentation.
Hello everyone, I am presenting a retrospective study of pediatric uveitic patient which we saw in our OPD from last 7 years data. So why we did this study? We want to know what the etiology of the disease and what are the major cause factor in the South Indian population. That is, we did a study at Narayan Nethralaya, Bangalore. So in globally, the uveitis at the pediatric population is around 5 to 10%, and in comparison to North and South India, its prevalence is around 3% at North and around 6% at South. So early recognition of this condition is important. So it was retrospective study. It was performed from 2015 to December 2022, and this data we have taken. Inclusion was less than 18 years of age and exclusion was more than 18 years of age. So there was 1,000 eyes of 687 patient as children, and mean age was 11 years. The gender wise, what we have seen is the male were predominant versus female. The ratio is 58:42%. And if we classify it to age wise, then more than as we have seen the uveitis as the children grows, the uveitis incidence in them is increasing.
So this is anatomical classification. What we have seen is majorly were based in the posterior uveitic group and less in the anterior uveitic group as been quoted in other various studies. And if we classify on etiological basis, in our study we have seen the infection were the major cause, followed by other idiopathic and non-infectious causes. In case of infection, what we have seen majorly is the toxo and the TB were the major. Rest other are in less percentage. Now on follow-up duration, what we have seen in the uveitic age group pediatric patient, the majorly complication they develop is the cataract, followed by macular scar formation as the posterior segment complication. The treatment which we have given most to them is the oral steroid, followed by systemic medication like for antibacterial and antiviral medications. Now we try to classify it into the age-wise distribution. Neonate infant less than 1 year, 1 to 6 years, and 7 to 12 and more than 12 years. So what we have seen is the infection is as age rises, the incidence of uveitis in them rises. This is same in as case of infectious and non-infectious. But infection we have found infections more in the less than 1 year of age versus non-infectious group. And toxoplasma versus tuberculosis, as these were the major our infections pattern, toxo was predominant in the less than 1 year of the age group versus TB. In non-infectious, VKH was the leading cause. It's most found in the more than 12 years of the age group. And this is the complication: cataract and macular scar. These are the anterior and the posterior segment complication. As we have seen, as the age increases, the complication in them increases with age, and posterior segment scar also increases with age. So as we have seen the pattern, when we try to correlate between them, as the cataract pattern and the macular scar pattern follow the same graphical representation. That means if patient is having cataract, then might be patient is having some posterior segment finding also. Oral steroid was started and it was major in the more than 12 years of age group. This is our sample study size. It was 687 children. Comparison with the other study, we have the largest group of the patient, and the posterior uveitis we have found in 41% of the population, whereas the rest of the population it's somewhere by 11 to and 27%. So other study, when we compare, the age group was the similar with our study was similar, comparable, and the majority of our study is having posterior uveitis, whereas anterior uveitis been reported in other northern group of population, and the cataract surgery was performed in our study also and other study also, and complication was cataract in their study also, and everyone started with topical steroid in their treatment. So posterior uveitis is the most common cause in our study, and complication is cataract followed by macular scar and retinal detachment, and we started mostly on the systemic steroid therapy followed by methotrexate.
I liked your study, but I think somewhere some stats were missing, like the proper comparison between infectious, non-infectious in different age groups. So I think there is no more need to work on it, because whenever we do such kind of epidemiological studies, so it should give us a very clear idea, like this age group, this many infectious, and as compared to the non-infectious. So that is the main, I think, basis for the study. I think these things were a bit missing. They need to work more on stats.
So good afternoon, everyone. So the role of OCT angiography as a prognostic tool in Vohwinkel-Harada disease. I'm Dr. Nitin Keshav Srinivasan. VKH is a T-cell mediated autoimmune disease directed against antigens found on the melanocytes. The inflammation primarily involves a choroidal stroma with subsequent involvement of choriocapillaries in the chronic recurrent stage. Despite the current management protocol of high-dose intravenous steroids and immunomodulatory therapy, 51.7% patients develop chronic disease and 6.9% develop chronic recurrent disease. The development of disease chronicity is a challenge in monitoring the choroidal disease as the disease becomes clinically silent once the acute stage is passed. The ST-OCT helps in diagnosis and monitoring the response to therapy during the acute phase. The ICGA is a sensitive tool for detection of minimal inflammatory changes in the choriocapillaries. It is a gold standard for monitoring therapy, and it's invasive with potential dye-related side effects. This is a picture of acute VKH, where in the OCT we can see the subretinal fluid and septae with thickened choroid, whereas in the ICG you can see the presence of hypersinus and dark dots along with the fuzzy choroidal vessels. Whereas in the case of chronic VKH, there you can see a sunset glow fundus, but the OCT looks absolutely normal with the choroidal thickness returning to normal. Whereas the ICG still shows the presence of hyposinus and dark dots or HTDs, which indicates the presence of persistent inflammation. So the aim of the study is to use OCTA or OCTA to use it in characterizing and localizing the microvascular changes associated with choroidal inflammatory foci in VKH. We analyzed and quantified the changes observed in the choroidal vasculature non-OCTA and compared these findings with other routine imaging modalities. We wanted to determine if OCTA images of choriocapillaries could be used in place of ICGA to monitor choroidal inflammation after the exudative stage. Retrospectively reviewed the case records of 43 consecutive VKH patients at a tertiary eye care center, and the patients underwent OCTA using Tropcon DRA Triton machine and EDA OCT with Spectalis and ICGA with Optos. And myopes more than 6 diopters are excluded, and all patients received treatment according to standardized protocol. Multimodal imaging was done, and each image was analyzed and readings measured by one mass-trained observer at each of the visits. The choriocapillary slab flow-wise were measured on OCTA within the macula, and each scan was automatically segmented by the Triton software to visualize the superficial capillary plexus SCP as well as a choriocapillary slab. The images of the SCP, that is, and the CC slabs were then imported into a MATLAB software. The superficial capillary plexus were then thresholded to get a binary mask, and this binary mask was overlaid on the CC choriocapillary slab. And then in the image, you can see the presence of the red lines, which are the vessels, and the green dots, which are the flow voids. This is to rule out any projection artifacts. 3 parameters were studied on the OCTA image. One is the number of flow voids, and second is the average size of the flow voids, third is the average area of the flow voids. So 43 consecutive patients for 86 eyes were diagnosed as VKH and who had undergone OCTA were recruited. 6 patients in the acute phase of the disease and 37 in the chronic phase of the disease. Majority were female. The median duration of the disease was 165 months. The mean percentage of area of flow voids, which is synonymous with the non-perfused choriocapillary area, was 8.76%. The mean number of flow voids was 902.6. The average size of the flow void was 11.88 pixel units. A positive association was found between the presence of flow voids in OCTA and presence of HTDs in ICGA. The odds ratio for detecting a flow void in OCTA in an ICGA active disease was found to be 6. The sensitivity, specificity, and predictive accuracy of OCTA to diagnose VKH were determined. The 3 potential diagnostic features which I mentioned earlier were studied, which we repeat as the number, the size, as well as the area of the flow voids. The number of flow voids, the flow void number was used as a predictor to identify HTDs in the ICGA, and it was found to have a sensitivity of 70.97 and specificity of 83.33. The area under the curve was found to have 0.77. Similarly, the flow void number was found to identify the clinically active inflammation, and an acceptable AUC of 0.75 was noted. And the OCTA parameters mentioned earlier were matched with ICGA activity and ICGA score, and they were not found to be any significant. So in discussion, VKH is a predominantly choroidal disease. The monitoring of the choroidal inflammation once the acute exudative stage is passed can be difficult as the inflammation becomes subclinical. Ongoing choroidal inflammation may be silently progress, becoming chronic recurrent unless adequately treated. The EDI OCT utility reduces as the choroidal thickness returns normal and becomes thinner with age and progression of the inflammation. So ICG is an invasive modality and cannot be repeated frequently. So in discussion, the positive association we also found between the presence of flow voids in OCTA and presence of high HTDs. The number but not the size nor the area of flow voids had both good sensitivity and specificity in identifying HTDs on ICGA. The predictive accuracy of the number of flow voids on OCTA and clinically active inflammation was acceptable. This suggests that the number of flow voids could act as a surrogate biomarker to detect active disease in VKH. The limitations include a small sample size. Only 6 patients were in the acute stage, remaining were in the chronic stage. Only octa images over the macula were studied, and the findings could not be applied to the rest of the fundus as we did not have a wide field OCTA. In conclusion, OCTA can be used to monitor the disease activity in acute and chronic VKH. A positive association was obtained between the presence of flow voids in octa and presence of HTDs in ICGA. The flow void number can be used to identify the HTDs in ICGA and is a good predictor of active inflammation also. The flow void chronic
cases of VKH, and your chronic cases of VKH were much more. In
Much
fact,
more.
43 minus 6 is 37. 37 eyes. How did you do the OCT angiography in acute cases, especially when there is a neurosensory detachment, subretinal fibrin,
so we had to exclude a few poor images, sir, because we could not get a clear image in all patients of acute VKH.
Do you have longitudinal changes which happen in a particular patient starting from the acute stage of the disease to the chronic stage? And what is the correlationship of the flow void areas with the HDD?
So the longitudinal, this is as part of this study, I did not put up the data, but whereas we could not find any longitudinal change when compared, because the number of acute stages only 6 in the study. So only in the 6 there were 3 patients who not had among 12 images where 6 were excluded because of the poor quality of image, because when there's a neurosensory detachment, the image of octa was very poor. So only 6 was taken. So a longitudinal study we did not want to do because only 6 images were there.
It was retrospective or prospective?
It's retrospective.
How did you blind the observer when it's a retrospective study?
So it's a retrospective. We only took the images, and the images were screened only by, we do not know the diagnosis.